All right, welcome everyone to our next session in our Boosters and Beyond series regarding holistic dementia care and antipsychotic drug reductions. This week, we have Marguerite McLaughlin, who's going to be leading the discussion on family education, family and resident education as it relates to gradual dose reductions. We would really appreciate and love for you all to join in on chat, put in your questions and comments as we work through the program, because we'd love to hear from you all and make this a conversation as much as possible. So before we get into the topic for today, though, we do have a couple of housekeeping items we like to get through first. So if you're not familiar with who we are the iPro QIN-QIO. So iPro specifically helps support the regions shown here as part of the Medicare QIO contract. iPro specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we're three organizations under the iPro QIN-QIO banner. So if anyone asks if you're working with iPro or Health-centric advisors or Clarent, or if you know who the QIO is, you say yes. Just a little update in regards to the COVID-19 vaccine. I know a lot of discussions have been going on as of late about what's going to be happening in the fall. We do plan on sharing information as we learn about it as well with you as well. You can see that the XBBB strain is the most dominant currently at 84.2%, having a little bit over a quarter to close to half of the population with the updated COVID-19 vaccine for adults over 65. So definitely some still opportunities to continue to encourage the bivalent booster, as I'm sure you're all doing. And currently, this is the heat map, so to speak, of the current reported COVID-19 for hospital admissions per 100,000 within the past week by county. So majority of the country doing pretty good, but there are still some hot spots across the country that those regions should be mindful of. So for this week, we're going to be, as I mentioned, talking about family and resident education in regards to gradual dose reduction. So we know that providing dementia care education can help encourage the family members to be more on board. It's a very difficult conversation to have with the families who have seen their loved ones maybe stable on some of these medications and really don't want to rock the boat, and not having the full clear understanding of what these medications can negatively do for their loved ones. But we're going to be talking about some effective communication strategies that you can have with those families and go over those concerns in regards to those gradual dose reductions for those antipsychotic medications. So we have a lot coming in, Margie. I'm going to turn my attention over to that for a minute. So I'm going to pass it over to you to get us started.
Okay. Just want to say hi, everybody. Thank you so much. You've got a great team here behind me, so I invite them to jump in as well because they've got some great experience in working with folks who have dementia and doing it in a really compassionate way. So I just wanted to take you back. If you haven't been with us these past 12 weeks, what you might not know is that we started off by having a conversation about a particular toolkit that we created. And in it, what we did was we identified some very specific changes that organizations could make, or perhaps maybe heighten performance in certain areas. But these particular things always make a really remarkable difference. And you can get it here. Josh will pop it. I guess he already has. God bless him. He's already popped that in the chat. Thanks, Josh. And if you go to the next slide, what you'll see are there are pretty much like 8 steps. And the main part of the National Dementia Partnership actually worked really hard and put together this change package and then practiced it and did a pilot test with a wide array of Maine nursing homes in order to ensure that they were, all the working parts were in order. And so you'll see here, as Josh kind of flips through, you'll be able to see these are the 8 different features. One was a first line of defense, which meant that kind of everybody was singing from the same choir page. People understood why we limit antipsychotic drugs, the effects that they have on residents. The second was creating a therapeutic environment. And in the toolkit, in the change package, it actually has a very, very awesome kind of experience of walking you through how to begin to think about having a therapeutic environment. We also talk about a data-driven dashboard, and that's a way to keep track and really help to ensure that the folks who have dementia we're taking a look at their behaviors and expressions, keeping track of some of those things so that we know we're delivering the best care possible. We also know when it's time to try other interventions in order to make them comfortable. And then obvious and demonstrated competencies is the 4th part of the change package. And it literally walks people through ways to think about helping your staff to begin to speak fluent Alzheimer's, and what kinds of competencies people need to be really great at delivering the kind of care that we're going to describe here today. Hospital transition process is part of it. 6 is family education. And so today, my job is to focus on family education. I can share a little bit from the home that I worked at, but I also worked at the Alzheimer's Association for many years. And so I'll share a little bit about some of the things that we made a real effort to help families to understand. Last, 7th is process for gradual dose reduction, which we'll also talk about today in relation to education to families. And then last but not least, this physician and medical engagement, how to get people really engaged in a philosophy of care that puts comfort and people first. And so that's really what we're all about in this change package. And so today I'm going to talk about number 6. Josh, can you get me to the next one?
Yeah, Margie, just before we move on to the next slide, I just wanted to just really take a moment to highlight the importance of the order that this is all in. Just from the QIO standpoint, we speak with a lot of facilities, provide a lot of support, go on site, and we work with a lot of facilities. And I got to be honest, a lot of facilities don't have a systemic process like this in place. A lot of the situations I've seen facilities try to implement a gradual dose reduction, it's almost like they start there rather than putting all these things in place, and then they throw their hands up and say, see, we can't do it. We can't take them off the antipsychotics, and we have to keep them on. But they don't have any system in place. They don't put any of these processes in there to help ensure that those gradual dose reductions are successful. So I just wanted to emphasize the toolkit itself, but even just looking at how it was framed out and all the things that you should be doing before you even attempt that gradual dose reduction to help make it successful. So just wanted to put my 2 cents in there.
Always appreciate you chiming in, Josh.
Yeah.
Number 2 is my favorite. Therapeutic environment. I'm all over that.
Yeah.
If you look at this, here's where we're going to focus. And so when we think about family education, sometimes it's on the fly. Lots of times it's like when something's happening that families get the boatload of education. When you stop and think about it, lots of them are even new to nursing homes. Suddenly their life changed. They bring a loved one to the nursing home, and suddenly they're learning nursing home speak, and they're trying to fathom a lot of information all at one time. And so a lot of times some of the things happen on the fly, but one of the things that we really recommend as part of the change package was to actually really kind of set aside a really designated time on your calendar 4 times a year, quarterly, to do a family education. And what I mean by that is have dinner. My pal Hugh Hall at Westview used to make it a point to always have great food. He used to put together a wonderful dinner, but then he used to have hard-hitting, really great conversations with families so that they felt connected to each other. Lots of family members who kind of had a common interest in that they all had a loved one who had dementia. One of the things that we used to do was kind of walk through these particular things. And so we set up our education for families in this way. Certainly there's lots more to know, but these key things really help people. So the first one, some of the dementia basics, because you know what? Back when they were home and they were taking care of a loved one in the house, there wasn't a whole lot of time for studying. And a lot of times they were watching their loved one kind of disappearing on them. There was a lot of stress to it. And so it might surprise you, and probably won't surprise any of you, that lots of our folks actually come to the nursing home without actually knowing a lot about dementia. And so part of it is really helping to double down on helping people to understand what's going on, and very importantly, the philosophy of care that you espouse in your organization. We really talk up and strongly support a person-centered care model, person-directed care, individualized care, a lot of names for it, but more than anything else, making sure that it's custom and tailored to each one. So once we get past like the basics, we also begin to talk about some of the risks, and I don't have to tell any of you what those are, but we'll just kind of go through it real quick. Some of the approaches that we use, both creating why we would go toward using antipsychotic drugs if needed, and more importantly, why we'd take somebody off. And so walking the families through the actual process of that. And so on the next slide, what you'll see is that we begin that whole dementia basics because we get people, families really thinking about all the behaviors actually happen for a reason, and that it's all about communication, their loved ones' communication. That becomes a big deal because a lot of times, families, I don't know how many times I've counseled families who are like, he's doing that to spite me, or they would have all kinds of really interesting and really emotional reactions to their loved one's disease. And when we started helping people to really start to think about it in terms of it's a form of communication, that kind of centered them in a different place. It wasn't about their marriage or how somebody was trying to cause a ruckus in their household. It was really a new centering point for a lot of our family members. So the next one,
Margie.
Jump in.
Yeah, no, I'd just like to add, because I think that's really an important point. We're not always sensitive to the hypervigilance that the families develop, having cared for somebody with dementia in their home, and they become very sensitive to us making changes or considering changes. So I just admitted somebody who has dementia and has been on risperidol in the home, and had probably in the course of my initial visit with them said something to the effect that it would be nice to at some point get her off of this medication. And this was interpreted that I had already stopped the medication, and I got 15 phone calls and messages about, Dr. McNichol, please call us back because you stopped this medication, which was never stopped. But I had put a 2-week to reassess in 2 weeks, which is what we're supposed to be doing. So, the family just freaked out essentially. Yeah. And so I don't remember exactly what I said, but something in there triggered them. And we have to just, step back and then recognize that they're anxious about these things. And, they interpreted every behavior that has happened in the last week because the risperidol had been stopped when the patient had been getting the same medication all along. So,
wow, thank you.
It's just an example. It's a current example that I'm currently dealing with of how they're just very sensitive, and we just have to be cognizant and patient and recognize that and acknowledge it.
Yeah, very emotional. Lynn, thanks for chiming in. It's as much compassion for our folks who have dementia as it is for their families, because it's a really tough thing for people to go through. On the next slide, we just take that a step further and you kind of catch the red. It's about communication. All behaviors, the crying, the hoarding, the smiling, the mumbling, the hugging, wandering, hitting, scratching, babbling, fidgeting, fighting, friending, and laughing, all types of behaviors, what's everything from a toothache to my life when I grew up during the Depression are all big ticket items and factor into this. So helping families to understand that becomes a part of the story. We used to break it down like this, and I put it here on the next slide because I think it's so important, because it kind of trims down the conversation. So we used to always teach families that if all behaviors or expressions were a form of communication, think about it in terms of these particular areas: physical and emotional, like what's going on physically and emotionally for folks. What's going on in the environment? Is it too loud, too hot, too everything? Is the lighting, is there glare? Is it like, I hate summer, I hate being hot, all those kinds of things play into it. Same with communication, how people approach them. When they come in and at 4 o'clock and they come with all the dirt on what happened at the family event, and come in and blow into somebody's life with a lot of emotional baggage, and does somebody suddenly have a much more likely to sundown, and so helping families sometimes to even recognize the part they're playing in that becomes important too. You don't want to chastise folks, but sometimes really helping families to recognize the part that they play in that becomes an important piece of the story.
Margie,
I was just going to say, I saw you come on
one of the things when I was when I worked and was teaching some of this, I used to talk to some of the CNAs and simply say, think about our cell phones. We use punctuation, 2 dots and a parentheses mark to express our emotions, correct? 2 dots and a parentheses to make a smiley face or a frowny face. If we can use dots and lines to communicate emotions, imagine what we are expressing with our face and our body language to the residents. And what are they trying to communicate to us with their face and their body language?
Love it.
I mean,
yeah, implied judgment and tone. I mean, rolling your eyes and stuff.
Right. What lines and dots, by just angling things differently, we're communicating completely different things, but in electronic devices. All of this can be used. It can be a superpower for good or evil.
For evil, I appreciate that. It's all in the approach, isn't it? It really
right. And for the residents who can't get the words out, they're trying to use all of this to make our staff like, come on, dudes, listen to me. Yeah. Would you please hear me? Right?
Totally get a notion. Yeah. Josh, give me the next slide if you would, because one of the things we used to hold to was what we called the zone. And you can kind of see here, and it's something that we literally talk to families about, is we're trying to what we call hold the zone. And the zone is that place of comfort, it's safety and security, well-being. That's why, like, whatever it takes, give somebody comfort and keep them in that comfortable place. That's really what we're working on. And that whole notion of a therapeutic environment, thinking about the physical, the emotional, the environment, the tasks, the communication. And so what we used to recognize was that when we start to see somebody falling out of the zone, that's when you apply an intervention. And so if we're gonna try to keep people off of antipsychotic drugs, we have to be so sensitive to watching as people begin to stir, as people chew their lip or, fiddle with their hem. And we start to see those little subtle things happen. And that's when we come through with an intervention so that we can avoid what my team used to call a comfort crisis. So we're trying to keep people in that zone. Families get this. Families get this. They do think it's impossible for you to do it without drugs, but you can, and it's possible. So when we think about those, if your organization holds this philosophy of care, the person-centered approach, really tailored, watching for those little subtle things, all the behaviors, communication, if people are doing that kinds of things, staff know how to investigate, and they're watching behaviors, and they're holding that zone, and the staff are really highly skilled. When all that's going on, a family can feel comfortable that you have the capacity to minimize antipsychotic drugs in that organization because you've got other stuff, you've got the great juice flowing that makes some of this really work very, very well. So needless to say, second part of our story in education on the next slide, and I won't belabor the point because we've talked about it so much, and Rob and Lynn and Dennis have done a great job in talking about the risk, everything from falls and all that stuff. But certainly it's a well-known and well-documented thing, the risks. And so one of the things that we used to do is walk families through a lot of those risks. We don't want we don't want folks falling. We don't want all of those all that ambient noise for somebody with dementia's life happening. And so there's lots of risks that come with it, and we're trying to avoid that as much as possible. And when we can get families to recognize some of those risks, and as Lynn pointed out, it's emotional. So yeah, it might take a little work in order to get there. So I'm just touching on that one. So there's we want to be sure to give them a good basic education. We want to be sure they know the risks. Josh, next one. So some of the approaches to behavioral expression management. So we're trying to kind of, what are we doing to kind of keep all of this working? So we want to get really clear on what the behavior is. So what's the reason the person's either on the medication or needs to be, if at all? And can an intervention, what are some of the reasons for those behaviors? What are some of the non-pharmacological approaches that we're either trying or willing to try in order to mitigate some of that? And then order medication as a last step. And so when we can frame it for families in this way so that they can see some of those approaches, makes a big difference. Taking that a step further, you can kind of see in that breakdown on the next slide, you'll find that we can think about the non-pharmacological interventions as simple things, kind of back to what we were talking about, those sensory things like music therapy and pet therapy, and big golden retrievers that show up to just bring joy to places. Simple things like massage. Some people hate massage though, so knowing who loves that kind of stuff. And then even stuff like light therapy, finding more and more success with some of that. Environmental, making sure that people have adequate space or can get outside, or feel like they're free, because sometimes in our settings it can be a little stifled and a little stuffy. So not just getting outside, but helping people to feel that they have space. We used to have a beautiful chapel at my place, and it literally was in the care plan as one of our behavioral interventions, because for some of our folks that worked really well. Positive reinforcement, and I don't mean it in the give them a cookie kind of thing. I just mean helping people to feel supported, and that people are giving them positive reinforcement along the way. Redirecting folks where appropriate. It's a way overused word, but there are some really nice things that you can do in avoiding reality orientation. Helping families to know that's kind of key, because folks are still on the oh, come on, Harry, Ethel died 22 years ago, and it's kind of like, yeah, it's not happening. So for folks to start to really understand what that's all about, and then communicating in shorter sentences in adequate time. So helping folks to understand that those are some of the key non-pharmacological interventions. And then a few more on the next slide that we kind of work with families around. Whoop, I'll just pass by that one.
Yeah, I
And,
think it's broken for some reason. Sorry about that.
Oh, not your fault. So we begin to look at those expressions, those behaviors, and we begin to target them. Like, when are they happening? What's happening? And right now in our current climate, I don't kid myself. I know folks are really deep in the weeds on what they could possibly do with the time they have during the day to take care of folks. But, you pick up on subtle things because you're around residents all day. And so there's still the opportunity to kind of have a sense of when some of these are happening. So before we even talk about psychotropic drugs, we begin to target what is the actual behavior or expression that you're actually trying to mitigate. What are you working on? Because just because they have dementia isn't the reason. So we really want to kind of hone in on some of those and look at some of the challenges and risks in the care, and in making sure that we're targeting that in the care plan. And then we're talking with lots of folks about what those expressions or behaviors are looking like. Are they happening more at different times of the day? Do families have some insight into what's going on and why that might be happening? And then making sure that we document individualized, as we mentioned before, these non-pharmacological approaches. You don't want to put anybody on anything or take people off until you have some really great things in place. Trying is foolhardy. You get well practiced with your staff on the interventions and know which behaviors you're actually trying to lessen, and implement those interventions and approaches across all the various disciplines. Next slide, Josh. Kind of looking like this. So behavioral tracking, we're thinking about identifying the targeted, behaviors. We're monitoring some of those and looking for some of those episodes, making sure their care plan, tracking them ideally for several days. So maybe like 2 weeks, a week, 2 weeks, what are you seeing? And be sure to be talking this stuff through with your CNAs, because they know what's going on. They have it all down really well. Make sure they're helping to track some of it, because it can make such a difference for the well-being of a resident. If people are tracking well, you're going to do a much better job of bringing comfort to that resident and to the families as well. So next slide. Then we just kind of scoop along here. And then when we think about sharing with the families, we can share with them how we're going about keeping track of these behaviors, how frequently they're getting an idea that we've kind of got this thing under control. And so I think they have a better sense of confidence when they're working with us, that we're really pros at this. Without good documentation, there's a potential that psychotropic drugs are viewed as chemical restraints. So we don't want that, certainly. And sometimes they can be prescribed for behaviors, there's possibility of keeping them unnecessarily on something. So if we don't nail down what it is that we're giving it to them for, that becomes a big part of the story. And it can also cause significant distress or harm for folks. Next slide. When we break it down to the why for gradual dose reductions, this is where we share with families. This is our fourth piece. And the why for gradual dose reductions is to emphasize on it, that we have this approach, it's individualized, and that we have ways to offset what's going on. We can share with them these non-pharmacological interventions, antipsychotic rates across our region, working in our minimum data sets to highlight some of those different features, and ensuring folks and helping people to understand that we've got a great team who's working on this all together. We have little committees and different groups that can actually help to even heightens some of the ideas and interventions. And then one more is this last one, where helping families to understand the actual gradual dose reduction process. And so if we get to that point, we have all these things in place. We begin that titration over the 1 to 2 weeks, usually about 2 weeks, with a physician's order. All the staff ensure that family understands that all the staff knows that we're going to go through this GDR process together, and they know that the dosage reduction is occurring, and it's certainly allowing for periods of adjustment as we're going through this process together over that time. Use non-medication interventions and treatments, and then documenting and communicating with other staff members. And what does that look like? I'm at the end of my time, but this is pretty much what we think about. I think I'll pass on that one, Judge, and let folks any last questions or anything people want to share. So think about those 4 things when we're talking about educating families. Anything anybody wants to share?
Margie, that was really excellent. I want to commend the group. And also I wanted to just say that last slide that you talked about is really the key, because everybody in the whole facility, that's taking care of that resident needs to know what's going on whenever a medication is changed. It's so crucial to having a successful GDR. So thanks for highlighting that.
Thanks, Rob. Thanks, everybody.
All right, that'll be it for today's session, everyone. If you know anyone who would benefit from today's session, we do have this recorded and we'll be playing it again tomorrow at 3:30. So encourage them to come to that as well. And then we also have our IP3 session this Thursday at 11. I hope to see you all there. If you thought that today was a good use of your time, you thought it was helpful, please let us know in chat before you head out. It does mean a lot to us and help inform us for our future presentations. Excellent. Thank you so much, everyone. Have a good day.